induced agent in the cell is accumulation of some material intracellular. They are different. Okay? We have accumulation of lipid, content of cholesterol and triglyceride. We have accumulation of protein, glycogen, pigment, and ultimately we have pathology calcification in the tissue. Accumulation of cells intracellular can be in cytoplasm, can be intracellular organelle. And in some situations, some material accumulate in the nucleus. Some of tissue synthesis by affected cell, but some of them produced elsewhere, also from environment to cell and accumulate. We have many material to intracell. For example, normally we have lipid, we have protein, we have water, and fat to intracellular. But in pathologic situation, we have exaggerated accumulation of fat. For example, fatty changes, protein, and carbohydrate. Some of accumulation are due to abnormal metabolisms and deficiency enzyme. For example, in storage disease, inborn error of metabolism, and in other, we have accumulation of pigment, endogenous pigment or exogenous pigment in the cells. They have affected shape and functional cell. What is the mechanisms of accumulation of some material in the cells? Then we have abnormal metabolisms. For example, abnormal metabolisms of lipid. We have fatty changes. Okay? After reversible cell injury is also due to hypoxia. We have fatty changes. Then we have aggregation of misfolded protein. Protein folding has error. We have accumulation of some protein intracellular. For example, alpha-8 antitrypsin accumulation. Also, when we have lack of enzyme. For example, in our body, we have phenylalanine. Phenylalanine, due to enzyme, converted to metabolite necessary for cell. But when we have deficiency of enzyme, we have accumulation of primary material rather than substrate in the cell. And it's toxic for some cell. And also, we have ingestion of indigestible material in the cell. Cell don't have any mechanism, any enzyme for removal of this material. So this material accumulated in the cell. The fatty changes is very, very common. All of obese patients, all of patients with low activity, and diabetes mellitus, and abnormal metabolism with fat has fatty changes in the cell. It's very, very common in the liver, but in other organs, for example, kidney and heart, we have fatty changes. Fatty changes occur when we have overproduction of fatty or we have normal production of fatty cell. We have normal production of fatty cell, but we have abnormal metabolism of fatty and aggregation of fatty cell in the cells. Fatty changes is called steatosis, fatty metamorphosis. Then we have accumulation of intracellular triglyceride. Common in liver, but we have fatty changes in heart, in kidney, in surrogated muscle, and other organ less than this organ. What's cause of fatty liver? We tell about abnormal metabolisms. What is some etiologic agent for fatty liver, especially alcohol abuse is very common. Alcohol abusers have fatty liver, diabetic metabolisms with abnormal metabolisms of liver, obesity and resistance to insulin, protein malnutrition also associated with lipid accumulation in the liver. Some drug and toxin, for example, tetrachloride carbon, in some patients associated with fatty changes, anorexia and also pregnancy. So, what is mechanisms? This figure shows mechanisms of fatty acid accumulation in the liver. Then we have free fatty acid reabsorbed from intestine. Fatty acid enter to liver and combine with acetate, and also in some process convert to triglyceride. But some of fatty acid oxidated to ketone body, some formation phospholipid and cholesterol ester necessary in our body, and triglyceride combined with apoprotein, lipoprotein formation exit from liver. Decrease or abnormal in this abnormality in this pathway associated with fatty liver. For example, excess entry of lipid to the liver in this patient have hypertriglyceridemia with intake of many fatty or unprocessed food. And also, when we have decrease of protein synthesis, when we have liver damage, protein synthesis is damaged, or hereditary abnormality with decrease of protein synthesis, we don't have enough lipoprotein and fatty remain in the liver, or decrease oxidative of fatty acid by mitochondria. Also, we have many triglycerides and aggregate in the liver. So, in this situation, we have fatty liver. Now, we review the morphologic changes. It's normal liver. Cytoplasm of cell are eosinophilic. It's nuclear material and cytoplasm. After accumulation of fatty in the liver, we have free and clear vacuole. Is show what we in the vacuole. Vacuole is a type of triglyceride. I tell you, after tissue processing, triglyceride is removed, and free space is a representative of fatty changes in the liver. Fatty changes is susceptible to other abnormality in liver, became inflamed, and after a time, irreversible injury is occurred in the liver. It's very, very common in industrial country. Also, we have cholesterol deposition. The most common site of cholesterol deposition is the vascular wall, subendothelial area. We have atherosclerotic plaque, or accumulation of cholesterol, and narrowing of the lumen. The cholesterol deposition became larger and larger, and after damage to the endothelial cell associated with a clot formation and narrowing of the lumen. Oh, okay. I forgot. Yes. This cholesterol accumulation in their vessel wall and became thicker, and when we have a damage in the endothelial cell, we have formation of clot and ischemia is occurred. For example, it's very, very common in coronary artery and is associated with myocardial infarction, and also cerebral vascular is associated with CVA. Also, we have accumulation of protein. Protein is necessary material in the cell, but in some situation we have excess production or failure to remove of protein from the cell. For example, in kidney, when we have nephrotic syndrome, in nephrotic syndrome, we have excess amount of protein in the tubule because glomerule don't have reabsorbed protein and protein accumulated to the kidney. And also, we have Russell body. We have plasma cell proliferation. Plasma cell produce immunoglobulin, and immunoglobulin is a protein, aggregate intracellular, and monoid body or alcoholic hyaline in the liver. They are example of protein accumulation. Accumulation of protein in the tubule of kidney in nephrotic syndrome, tubular proteinuria, accumulation of protein in the plasma cell, accumulation of protein in the liver, or neurofibrillary tangle in neurodegenerative disorder. Also, we have glycogen accumulation intracellular. For example, patient with blood control in diabetes, there is accumulation of glucose intracellular. Glucose accumulation in renal tubular epithelium, cardiac myocyte, and beta cell is a cell of Langerhans. And also, when we have glycogen storage disease, we have accumulation of glycogen in solid organ. Also, we have pigment, intracellular pigment, exogenous pigment, and endogenous pigment. Exogenous pigment, the most important example is carbon. We have many A-fluid, such as carbon, in the environment, and we have accumulation of this carbon in respiratory tract. Also, Patho. Patho is common in some people, and the presence of Patho in the skin is seen as exogenous pigmentation. And also ingested pigment, such as lead, such as carotene, and such as silver. But we have endogenous pigment, production of pigment in excess amount accumulated in the cell. For example, production of melanin, okay? The pigmentation in the skin is production of excess melanin, and also production of hemoglobin when we have hemorrhage, and on some patients with congestive heart failure, and lipofuscin or previously called aging pigment. Okay, this figure shows accumulation of carbon in the lung. Okay, we see some strip of black discoloration in the lung, and in the tissue we have the position of black carbon material intracellular. In low amount is asymptomatic, but in high amount damage to the cell is occurred, and on lung anthracosis and fibrosis is occurred. You explain this figure.
Jaundice.
Okay, jaundice. Because accumulation of which pigment? Bilirubin. When we have liver or liver abnormality, okay, for to remove of bilirubin or intracellular hemolysis, and some disease we have icterus. Icterus easily seen in sclera because sclera is white, and after discoloration with bilirubin became yellow, and also skin became yellow after a severe bilirubin accumulation in hepatitis or other abnormal liver function or biliary tract function. What
cardiac muscles?
No. Only describe this feature. Only describe.
It's have some pigmentation between, you can see this yellow pigmentation. So I think
What is
lipofuscin.
this? What is this?
Lipofuscin.
Okay?
Yeah.
No, no.
Lipofuscin.
Lipofuscin. Lipofuscin. Okay. Okay.
We call it lipofuscin here at some doctors. So
Yes, yes. Lipofuscin. Lipofuscin is accumulated intracellular after aging, after some damage to the cell. For example, cardiac muscle. And lipofuscin accumulated prenuclear area. Its nucleus, cytoplasm. And the color is yellow to golden. Okay? Accumulation of lipofuscin prenuclear. It's not associated with severe damage. And what is this?
this is melanin, skin.
No, no. Accumulation of submaterial intercellular after hemorrhage. After hemorrhage and degradation of arms. We have excess amount of iron. Okay? And in this situation, it's called hemosiderin deposition. Okay? Hemosiderin deposition is golden to yellow ground in the cytoplasms. And in a heavy amount causes damage to the cell. In hemochromatosis, in hereditary disorder, we have excess amount of iron in the cell. And this patient with many amount of transfusion of blood, for example, thalassemia patient or severe anemia patient need to multiple transfusion of blood, we have accumulation of hemosiderin intracellular. Can damage to kidney, to liver, to heart. But when we have yellow golden granule in the cell, we have some differential diagnosis. And we use from special staining, hair staining. The hair stain iron deposition from gold to blue, dark blue stain.
And is this slide important for our practical exam?
For
Practical exam? Important?
no, I don't know. Exam. I don't know. No, it's not. It's not. Okay. So, we have type of calcification. We have two types of calcification, okay? Dystrophic calcification and metastatic calcification. What is dystrophic calcification? In dystrophic calcification, we have damaged and necrotic tissue, okay? We discussed previously, when we have necrotic cell after 2 or 3 days, we have deposition of calcium. So, dystrophic calcification is occurring. In this situation, in dystrophic calcification, calcium level of blood is normal. It's not related to calcium, circulated calcium. But in metastatic calcification, deposition of calcium in the normal tissue without any damage, without any necrosis. Then we have excess amount of calcium in the blood. So when we have hypercalcemia, we have metastatic calcification. Because calcium level is high in the blood, deposit in the tissue, in the alive tissue, without any damage. It's called metastatic calcification. So in this figure, we have damaged cardiac valve, a necrotic cell in the valve of cardiac. We have dystrophic calcification in situation. Or when the patient have tuberculosis, necrotic area in tuberculosis has deposition of calcium. So when we see calcification in the lung, one of the diagnosis is all tuberculosis. Also, in the elder patient, we have the position of calcium in the blood vessel. Dystrophic calcification. Dystrophic calcification is a slide of practical class. Okay? The position of calcium in the large blood vessels. But pathologic calcification, we have the position of calcium in the live tissue. For example, in the soft tissue, we have the position of calcium. Or this figure, we have the position of calcium in the soft tissue. When we have hypercalcemia without any necros in the tissue. But what is main cause of pathologic calcification or metastatic calcification? When we have excess amount of parathyroid. Parathyroid is a hormone associated with increased uptake of calcium from kidney, from bone, from GI. So when we have hyperparathyroid function, we have hypercalcemia. Also, when we have accelerated damage to the bone, for example, in Paget disease. In Paget disease, and after prolonged immobilization, we have excess of calcium in the blood. Or some disease, for example, multiple myeloma associated with hypercalcemia and the position of calcium in the spray. When we have vitamin D toxicity, because absorption of calcium from intestine is increased, and renal failure associated with secondary hyperparathyroidism. In renal failure, we have hypocalcemia because kidney don't have absorbed calcium, and decrease in calcium activated parathyroid hormone, and PTH is produced, and we have secondary hyperparathyroidism. So, in metastatic calcification, associated with hyperparathyroid, associated with vitamin D toxicity, and also associated with some disease, for example, Paget, for example, immobilization, leukemia, multiple myeloma, and some disease. Okay, but what is aging? In cellular aging, we have progressive decline in replication or proliferative activity of cell. After the time of age, we don't have regeneration, such as newborn, such as young person. And we have cellular and molecular damage in their cell. So, the definition of aging is cellular senescence due to deficiency in replicative and repair ability. Many factors are affecting the aging of cell. For example, DNA damage. We have many damage to DNA. For example, electrical damage and some of injurious agents, some of toxic damage to DNA. Also, in aging, we have change in transcription from DNA and translation to protein. In aging, we have dysfunction of mitochondria, okay? And all of shortening of telomere, we discussed about it, associated with aging. What is telomere? In the chromosome, in the end of short and long arm of chromosome, we have repeated sequence of bonds. For example, TTA, GGG, repeat again, TTA, GGG, TTA, GGG, repeat and have a length of chromosome or supporting the end of chromosome. The length of chromosome after multiple dividing is shorter and shorter, okay? And shortening of telomere is associated with aging, with loss of ability to division in the cell. So we have etiologic agent. For example, environment and metabolic with production of reactive oxygen species, free radical, accumulation in mitochondria, and decline a DNA repair, decrease cell function. Also, telomere shortening, cellular replication is decreased, and abnormal protein hemostasis, aggregation of misfolded protein, or a small amount of necessary protein associated with aging. So cellular aging is occurring. But we have defense mechanisms. For example, caloric restriction. Caloric restriction is very useful to prevent of aging. We have increased insulin rather than IGF signaling, and target of rapamycin is decreased. In this situation, we have altered transcription. So we have DNA repair. We have protein normal hemostasis, and they are against the aging. This figure shows relation between telomere length and cell division. In germ cell, have telomere length in germ cell is not short after division. Okay, so germ cell ability to produce more and more. Stem cell also have decrease in shortening of telomere. So some stem cell have ability to divide and produce new cell. But normal somatic cell, after division, telomere is short and growth and replication is arrested. So length of telomere is very important. In our body, we have telomeres. Telomeres is an enzyme. This enzyme, after a time, short telomere length. But somatic cell, if became cancerous, telomere activity is again high, and replication of cellule in the cancerous situation is increased. Okay, this figure also shows some mechanisms of telomere. This yellow discoloration shows telomere length. This is telomere length. Repeat both sequence in the end of short and long arm of telomere. After a division in somatic cell, normally we have loss of telomere. Telomere became short and short after a division. And in aging, we don't have replication ability. So we have DNA damage, telomere and telomere inactivation, and we have aging. But when we have telomere reactivation in cancerous situation is also seen. We have cellular aging associated with progressive decline in lifespan. We have accumulation of mutation in DNA after a time of life. And also, we have decrease in cellular replication, cellular repair, because normal cells don't able to replicate after an injury. Some patients have hereditary disease with early aging. This figure shows a 12 years old boy with early aging because shortening of telomere. This called Werner syndrome. We discussed about progressive shortening of telomere. It's called telomeropathy. Okay, telomere length is reduced after a time. So in this situation, we have lost normal function of body. they have aplastic anemia due to abnormal replication of bone marrow. They have gray hair because aging is very early. And also defective protein hemostasis. Defective protein hemostasis is also important when we have accumulation of misfolded protein. We have exaggerated aging and is an agent for aging and replication of cell is decreased. Okay, we have biochemical signal pathway to aging process. Aging process is interesting for some physician because anti-aging agent is very useful for business, okay? And in some situation, it's useful for has therapeutic potential. For example, calorie restriction is very important. Reduce IGF-1 signal is very important to prevention from DNA damage and prevention of aging. Also, we know accumulation of damaged cell, accumulation of lipid, or endogenous substance activated inflammatory pathway. And the prevention of inflammatory pathway is an anti-aging. For example, when we reduce free radical in our environment, we can prevent from aging. And rather than chronic metabolic disorder, also accelerated aging process. Have a break.